Good evening, everyone. I hope I'm loud and clear. Today, we are continuing with our webinar series covering the urology topic. And let's wait for a few more minutes before more people join in. I would like to introduce to you all Dr. Umesh Nepal. He is the consultant and chief department of uro-oncology at BP Koirala Memorial Cancer Hospital, Bharatpur. He has also done fellowship in uro-oncology, and he's the program coordinator as well. He's one of the very young and energetic neurosurgeons that we have amongst us. And we'll be discussing about testicular tumors and its management. Dr. Umesh, can you hear us?
Yes, Dr. Bigal, I can hear you. Thank you so much.
So after this session, we'll be having question answer sessions. If somebody has any questions, please send in chat, and Dr. Umesh he will respond
Organizing this kind of
after the.
teaching learning activities. When we were students, we did not have this kind of opportunity, and everything we had was teacher or books. But now the teaching learning methodology is changing, and it's good to be a part of it. I would also like to thank Dr. Robin Joshi, Dr. Bikal Gimire, and the entire SSN Executive Committee for giving me this opportunity. Testicular tumors are not that common as compared to other malignancies, but it is an important topic because we are seeing a lot of patients who come to us who are in a bit not properly, or I should say uh, wrongly. I'm using the term wrongly with caution. Some of them are wrongly managed, so it is better to know how a testicular tumor patient who is a suspicious testicular tumor should be approached, or how it should be managed. Uh, let's start. Let's start with a brief introduction. As we all know, it's about 1% of all malignant tumors is testicular malignancy, and most common age group. Please let me know if I'm not audible because I have a bit of a sore throat. Okay. The most common age group is between 20 to 40 years, where the maximum testosterone level fluctuation occurs. And as you all know, most of them are germ cell in origin. More 90 to 95% are germ cell in origin, and most of the tumors are malignant. So, so when we talk of testicular tumors, we are talking about malignancy, and we are talking about germ cell tumors. So we will be focusing on malignant germ cell tumors of the testis in today's topic. And it is one of the very important cause of psychological and fertility problems in this age group of people. Talking of the incidence, the commonest age group, as we already said, 2 to 3 to 4th decade of life. The white is to black ratio is 4:1 in United States, and the right side is slightly more common than left side, probably because the right testis descends later, and because of the increased intra-abdominal temperature exposure, probably because of that. And talking about the socioeconomic status, the slight it has slight more preponderance for high socioeconomic status. And talking about the geographical distribution, the highest incidences are seen in Scandinavian countries, Germany, Switzerland, and in our part of the world, it is relatively less common than those developed countries. Let's start with the picture. This is one of the picture of my patients presenting with a huge right-sided testicular mass. And this is the surgery of the same patient. Even the orchidectomy in such patients can be challenging, because orchidectomy, most of the people think, is an easy surgery. At times, these huge tumors may pose a lot of problem while doing inguinal or high inguinal orchidectomies. This is another patient, one of our patients, with a very small, not that big right-sided testicular tumor, but he presented the bilateral inguinal lymphadenopathy. The inguinal lymphadenopathy, as we will see in the on further slides, not that common. The cause of inguinal lymphadenopathy in this patient is that the disease had infiltrated into the scrotum, and then the inguinal lymph nodes were involved. Coming on to the classification, as I already said, they can be mostly germ cell neoplasm or non-germ cell. Non-germ cell can be arising from the Sertoli cells or Leydig cells, but we will only focus on the germinal neoplasms today. And they can also be broadly classified into seminomas and non-seminomas. The seminomas account for around 40% of the total and can further be classified into classical seminoma, anaplastic seminoma, or spermatocytic seminoma. The classical seminomas or typical seminomas are most common, around 80-85% of the total seminomas, whereas others are not that common. And among non-seminomas, it can either be a embryonal carcinoma, teratoma, choriocarcinoma, or yolk sac tumors. So broadly, for management, we can divide them into seminoma and non-seminoma. How do we diagnose, or what investigations should we do? This was taken from EAU guidelines. The most important thing is that testicular ultrasound is a mandatory test. Why? Because we have to assess the contralateral testis. In this testis also, we have to see the size of the mass, where it is located, what is the status of the epididymis, and also to know the vascularity, because with ultrasound you can see, with the Doppler we can see whether it's vascular or not, because testicular tumors are highly vascular. The guideline also says that biopsy of the contralateral testis should be offered to that patients with high risk of contralateral testicular intraepithelial neoplasm. Who are at high risk of testicular intraepithelial neoplasm? Either if the patient had a history of orchidopexy for undescended testis, or if the volume of the testis is less than 12 mm, then these patients are at high risk. And in these cases, the biopsy of the contralateral testis is also recommended. And the most important thing is orchidectomy. Orchidectomy, by here orchidectomy, we mean high inguinal orchidectomy or radical orchidectomy. Radical orchidectomy or high inguinal orchidectomy is a part of investigation in case of testicular cancers, because that way you will come to know about the tissue diagnosis and T staging. And with the tissue diagnosis and T staging, we go into further management strategies. We will talk about it in the coming slides. Another important factor in case of testicular tumors is the determination of serum tumor markers, which can either be alpha fetoprotein, beta HCG, or lactate dehydrogenase. And one thing all the residents must know is that these serum markers should be performed before surgery and about 1 week after surgery. After surgery meaning a radical inguinal orchidectomy. Then if and on the basis of the post-orchidectomy serum levels, then we decide further management. The state of the retroperitoneal, mediastinal, and supraclavicular nodes and viscera must be assessed with the help of CT scans. Recommended tests, as I said in the previous slide, serum tumor markers in all patients, abdominopelvic CT in all patients, chest CT in all patients, testis ultrasound bilateral in all patients. Why? I already said. Bone scan MRI only if the patient is symptomatic, if he is showing symptoms of bone metastasis. Brain scan in case of symptom and the patient with metastatic disease with multiple lung mets and or high beta HCG levels. And sperm banking, yes, this is very important. Sperm banking should always be talked about if the patient is unmarried or if he does not have a child, because after orchidectomy and if the patient is going to be subjected for chemotherapy, then the contralateral testis may also he may not be able to give birth to offspring. So sperm banking should always be talked about. We do not have that facility in our country so far, but still we need to discuss about these things to the patient. Coming on to the TNM classification, this is AJCC, the 8th edition, the latest one. As we all know, it is divided into TN and M. The only difference between TNM classification of a testicular malignancy and other malignancy is that here we have TNMS classification, where S stands for serum tumor, uh, tumor marker level. In T, further subdivided into T0, TIS 1, 2, 3, 4. P is pathological, C is clinical, and N, N0, N1, N2, N3. N0, no regional nodes. N1, metastasis with a lymph node mass 2 centimeter less in greatest dimension, or multiple lymph nodes non more than 2 centimeter in greatest dimension. This is clinical N staging. We'll talk about pathological N staging in the next slide. N2 is metastasis with a lymph node mass more than 2 centimeter, but not more than 5 centimeter in greatest dimension, or multiple lymph nodes, or any one mass more than 2 centimeter, but not more than 5 centimeter in greatest dimension. And what is N3? N3 is metastasis with a lymph node mass more than 5 centimeter in greatest dimension. By clinical N staging, I mean that the radiological, by doing CT scan, we can assess the size of the lymph node in the retroperitoneum. The pathological N staging, N0, no regional lymph nodes. N1, metastasis with a lymph node mass 2 centimeter or less in greatest dimension, and 5 or fewer positive nodes, none more than 2 centimeter in greatest dimension. This is only possible after the retroperitoneal lymph node dissection. N2, metastasis with a lymph node mass more than 2 centimeter, but not more than 5 centimeter in greatest dimension, or more than 5 nodes positive, non more than 5 centimeter, or evidence of extranodal extension of the tumor. N3, metastasis with a lymph node mass more than 5 centimeter in greatest dimension. In case of M, it is further subdivided into M0, M1, M1 further divided into M1A and M1B. M1A is non-regional lymph nodes or lung metastasis. M1B is any other sites other than lung or regional nodes. Now coming on to the serum tumor S, serum tumor markers, further subdivided into S1, S2, S3 on the basis of the LDH, beta HCG, and alpha fetoprotein levels as shown in the picture. One thing what the residents must always understand is that this S is not the pre-operative serum marker. It is after the orchidectomy. The patient radical inguinal orchidectomy, patient comes to you after 10 days or 12 days with the histopathology report. Then you again repeat the tumor markers, and this is the report after the orchidectomy. This is staging. One thing very different from other malignancy, as you can see in the picture, testicular tumors do not have stage 4. See, it's only divided into 1, 2, and 3. 1 is further subdivided into A, B, and S. 2 further subdivided into A, B, and C. And 3 further subdivided into A, B, and C. Here, what you can see is that T stage does not matter for staging. T stage does not have that much of importance. What is important is N, M, and S. As you can see, stage 1 is the NET, but N0, M0. 1A is PT1, N0, M0, S0. 1B is PT2 to T4, N0, M0, and S0. So, with NET, no node, no metastasis, serum markers normal is stage 1, which can be A or B on the basis of whether it's a T1 or from T2 to T4. What is stage 1S? 1S is NET, N0, M0, but the serum markers are positive, 1 to 3. Then it comes to the stage 1S category. This means a patient comes to you after radical inguinal orchidectomy. There is one report, suppose it's seminoma. The imaging does not show any intra-abdominal or retroperitoneal lymphadenopathy or metastasis, but you repeat the tumor marker and it's still somewhere between 1 and 3. Then it comes under stage 1S category. And what is stage 2? Stage 2 is further subdivided into A, B, and C. Stage 2A is N1. See, if it's N1, it is stage 2A, but it has to be M0. 2B is N2, it has to be M0. And 2C is N3, and it has to be M0. If the patient is N3 and S1, it is still 2C. Stage 3, as I said, it's further subdivided into A, B, and C. 3A, if it is M1A. 3B, if N1 to N3, but S2. Okay, and stage 3, any T, any N, but if it is S3 or M1B, then it becomes stage 3C. So more or less, stage 3 is a metastatic disease. Even though we do not have stage 4, stage 3 is more or less equivalent to stage 4 of other cancers. So this thing you must remember. This is the difference between testicular cancer and other cancers. This is another important thing. The International Germ Cell Cancer Collaborative Group have further subdivided the non-seminomas and seminomas into 3 different groups. The good prognosis group, the intermediate prognosis group, and poor prognosis group. Why is this important? Because for the prognostication and also for future treatment. For example, let's see good prognosis group. It can be different for non-seminoma and it can be different for seminoma. For non-seminoma, 56% of the cases fall into good prognosis group. The 5-year progression-free survival is 89% and 5-year overall survival is 92%. And it can be a good, the person can fall into good prognosis group when all of the following criteria are met, like testis or retroperitoneal primary, no non-pulmonary visceral metastasis, alpha-fetoprotein less than 1000, HCG more than 5000, and LDH less than 1.5 times upper limit normal. And in case of seminoma, 90% of the cases fall into good prognosis group. And if we compare the 5-year progression-free survival, it is 82%, and 5-year overall survival is 86%. And when all of the criteria are met, it's called the patient is kept under good prognosis group. Like any primary site, no non-pulmonary visceral metastasis, normal AFP, normal HCG, any HCG and any LDH, but the AFP has to be normal. Now coming on to the intermediate prognosis group, it's different, as I said, it's different for non-seminoma, it's different for seminoma. For non-seminoma, the 5-year progression-free survival is 75% and 5-year overall survival 80%. Only 28% of the cases fall into intermediate prognosis group in non-seminoma, and the criteria is as shown on the right side of the picture. Similarly, in seminoma, the intermediate prognosis group, only 10% of the patients fall into this group, and the 5-year PFS is 67% and 5-year survival is 72%. All of the following criteria on the right side have to be met for a patient to level as an intermediate prognosis group. Now, there is a slight difference in poor prognosis group. Seminoma is not classified under poor prognosis group, whereas non-seminoma is classified under poor prognosis group, and only 16% cases fall into this group. And if we look at the 5-year survival rates, they decrease drastically. The 5-year PFS is only 41% and 5-year survival is 41%, as compared to, if you see the good prognosis group, it drops from 89% to 41%. So this is how the grouping system helps to tell the patient about the future prognosis. It also comes in the management part, treatment part, we'll see later. So now talk about the stage-wise treatment options for germ cell tumors. Here, stage-wise treatment option means the patient has already undergone a radical inguinal orchidectomy and the histopathology report is in your hand, and the patient is diagnosed as either a seminoma or a non-seminoma, margins and all, T staging. Then further you do further treatment, depends upon this report and the serum marker level after surgery. So coming on to seminoma, clinical stage 1. Stage 1, as you recall, I just said it is N0, M0. Any T does not matter. So there are three options for seminoma clinical stage 1. It can either be surveillance or a dogleg RT, low dose, 20 to 25 gray, or 1 to 2 doses of carboplatin. Most of the patients in this group, in the clinical stage 1, the surveillance is enough in most of the patients. Up to 80-85%, only surveillance is enough. But only a handful of patients, 10 to 15, a maximum 20% of the patients require some sort of an adjuvant treatment. The most important challenge is to identify who require this kind of treatment. So many research was done, and there are many articles to show how we can identify who requires further treatment. Further treatment can either be, as I said, radiotherapy or a single agent carboplatin, which can be either 1 dose or 2 dose. There is controversy, but most of the literature says a single dose of single agent carboplatin is enough. So there comes the point, predictors for occult metastasis. So if these criteria are met, then these patients will require further treatment. But if these criteria are not met, then you can simply put the patient under surveillance. So what are the predictors of occult metastasis? If the primary tumor is more than 4 centimeter, or if there is invasion of rete testis in the histopathology report, histopathology of the orchidectomy specimen, then you have to subject the patient to further treatment. But if the primary tumor is less than 4 centimeter and there is no invasion of rete testis, simply keep the patient under surveillance. One thing I missed in the investigation part, which I thought I should have told you. We are seeing many patients, as I said earlier, which are slightly not properly managed. So what I recommend to the residents is that, yes, hydrocele is definitely a vaginal hydrocele, is definitely a clinical diagnosis, but please make a habit of doing an ultrasound of the scrotum. Why? Because the hydrocele can be a secondary hydrocele because of underlying testicular mass, which you might have missed. A small mass on clinical examination may have been missed. So we are getting many patients, quite a few patients who thought to be a hydrocele, a vaginal hydrocele was operated through scrotal route, but they end up seeing a testicular mass and they just close it and refer it to us. If you open up through the scrotum in a testicular tumor, then that's a blunder. So please make a habit of doing an ultrasound. Ultrasound of any part of the body these days are just becoming an extension of general physical examination. I have seen people keeping one ultrasound machine by the side of the examination table on their outpatient. So it's just a part of just an extension of the general physical examination. So my message to the residents is, please make a habit of doing an ultrasound before embarking on a hydrocele surgery. I should have told this earlier. I missed, so I told this now. So now coming on to the now proceeding further. So in the histopathology report of this seminoma, if the primary tumor is more than 4 centimeter, or if there is invasion of the rete testis, you need further treatment. If none of these criteria are met, then just surveillance. So what is surveillance? So in case of surveillance, you just call the patient on regular follow-up. I will show the timetable, regular follow-up, and examine the patient and do certain investigations. They have found that the 5-year relapse-free rate is almost up to 83%. And the overall relapse rate in unselected patients is just 16%. In low-risk patient, the recurrence under surveillance is less than 6%. So it's very justified to keep patient under surveillance. So what is the recommended minimum follow-up schedule for post-orchidectomy surveillance? Radiotherapy or chemotherapy in stage 1. This is as per EAU guidelines. They have divided into year 1, year 2, and then year 3 to 5. The procedures are divided into physical examination, tumor markers, radiography, and CT. In year one, the physical examination 3 times, that you call it 3 times means 4 monthly. Tumor markers 3 times, plain radiography twice, CT twice. In the second year, same thing for physical examination, same thing for tumor markers, chest CT and abdominal pelvic CT. But from year 3 to 5, then it decreases once a year. Plain radiography chest not required. Abdominal pelvic CT at 36th month and 60th month. This is the article which tried to compare whether RT is better or chemotherapy is better in stage 1 seminoma who required adjuvant treatment, MRCT 19 or EURTC trial. By chemotherapy, they meant single dose of carboplatin. By radiotherapy, they meant low dose of dogleg RT. And they have seen absolutely no difference. Both the curves, as you can see, just coinciding with one another. So you can either go for radiotherapy or a single dose of chemotherapy. So I think a single dose of carboplatin is much easier and can be done in those areas where radiotherapy facilities are not available. So chemotherapy is justified. Now coming on to stage 2B, 2A, 2B seminoma. So as if you recall the staging, stage 2A is N1, stage 2B is N2, more or less. And the further treatment depends upon the size of the retroperitoneal lymph nodal mass. So what is described is, if the node is less than 3 centimeter, that is non-bulky node, then you subject the patient to dogleg RT, same as before. But if the mass is big, if the mass is bulky means more than 3 centimeters, then patient is given chemotherapy. It can either be a BEP regime 3 cycles or EP regime 4 cycles. Then wait for 4 to 6 weeks. Then after 4 to 6 weeks, reassess with an abdominopelvic CT. So see here, and after reassessing with abdominopelvic CT, if the residual mass is less than 3 centimeter, we just observe. We do not need to do anything. But if the residual mass now, after chemotherapy and even waiting for 4 to 6 weeks, if the residual mass still is more than 3 centimeter, then this is the indication of FDG PET. So this may come in MCQ, or someone might ask you in Viva, what is the indication of FDG PET in seminoma? So this is the indication of FDG PET in seminoma. The lymph nodal mass more than bulky retroperitoneal mass. You had given chemotherapy, waited for 1 month, 1.5 months, did a reassessment CT scan. Still, the size is more than 3 centimeter. Then it's an indication for FDG PET. Now, if the report of the FDG PET is positive, then we have to go for resection of that residual mass which is there. But if the PET CT is negative, then we just observe. So this is also an MCQ question or a Viva question. What is the indication of RP-LND in seminoma? The indication of RP-LND in seminoma, if FDG PET is positive, after giving chemotherapy, you waited for 4 to 6 weeks, did a CT scan. CT scan, the mass was still more than 3 centimeter. You did a FDG PET, and if that PET scan comes positive, then that is an indication for RP-LND in seminoma. This is the Viva question I'm telling you. So this was one of our patients who, after undergoing chemotherapy, we waited for some time, as 1.5 months, then did a PET scan, FDG PET. Now you can see there on the left side at the renal hilum, it's a positive PET scan. You can see a mass with a positive PET scan. Same patient, different image. Now let's see what we do in stage 2C or stage 3 seminoma. Now the treatment depends upon whether the patient falls into good prognosis group or intermediate prognosis group. See, I told you before that the prognostication is also important in treatment. So this is the importance. If the patient falls into good prognosis group, then BEP into 3, If the patient falls into intermediate group, then he requires 4 cycles of BEP regime. That is the difference. This is just talking about the CT scans and imaging. This is one of our patients who had undescended right testis, and you can see the mass in the intra-abdominal testis, the mass just above the urinary bladder, and you can see the huge bulky retroperitoneal lymph node mass. See, primary tumor is quite small as compared to the retroperitoneal tumor burden. So this is what can happen in case of testicular tumor. So my suggestion, my advice to the residents is that whenever you see an retroperitoneal mass, whenever patient presents to you, he may come with a CT scan, he may come with an ultrasound finding saying that there's a huge retroperitoneal mass. If the patient is male, do not forget to palpate his testis. He may have a testicular tumor with a corresponding huge retroperitoneal mass. And this is the message I want to give to the residents. The same patient who after chemotherapy, the mass reduced to manageable size, and then he underwent the laparoscopic resection. Now coming on to the non-seminomatous germ cell tumor, how we manage non-seminomatous germ cell tumor. Now coming on to the clinical stage 1. So what is clinical stage 1? Same thing, there is no node. T can be anything, N0, M0. It is further subdivided. The treatment options here are also 3 options. Surveillance, RPLND, which can be lab versus open, depending upon your expertise, or primary chemotherapy. In case of seminoma, surveillance was enough in 80-85%, more or less 80-85% of the patients. Whereas in non-seminomas, around 70-75% of the patients, only surveillance is enough. RPLND or chemotherapy is required only around 20-21% of the patients. And the main important thing is how to identify who requires this further treatment. This is the challenge. And many literature, many research is based on this. We'll see. So first let's talk about surveillance, then we'll talk about the other options. The cumulative relapse rate in surveillance only in non-seminoma is 30%. 80% of the relapse seen in the first year of follow-up, and 60% of the relapse are seen in retroperitoneum. So what are the predictors of occult metastasis? So these are the predictors of occult metastasis, means these are the patients who require further treatment after orchidectomy. That is, you cannot keep the patient just on surveillance. So the predictors are lymphovascular invasion, proliferation rate, and embryonal carcinoma predominance. If the orchidectomy specimen shows there is lymphovascular invasion, or the proliferation rate is more than 70%, or the embryonal carcinoma predominance in the specimen is more than 50%, then he requires further treatment, which can either be surgery, RPLND, or chemotherapy. We will discuss in the further slides. Yes. Now this is the literature. It tried to compare the various aspects: vascular invasion, embryonal carcinoma predominance, and MIB score. MIB score is the same proliferation score which I said earlier. Out of these 3, they said that all these 3 are very helpful in predicting which patients will require further treatment. So the recommended minimal follow-up schedule in our surveillance as per EAU guidelines. Here it is divided as per year 1, 2, 3, and then 4 to 5. Also, the procedure is physical examination, tumor markers, plain radiography chest, chest X-ray, and abdominal pelvic CT. Year 1, physical examination 4 times, the tumor marker 4 times, chest X-ray twice, and CT, abdominal pelvic CT twice. The difference with seminoma is that in seminoma you only did 3 times in 1 year, that is 4 monthly. But here in year 1 you do 4 times. That is, you have to call the patient 3 monthly. Seminoma patient you could call 4 monthly. Non-seminoma patient you have to call 3 monthly. That is the difference. I just wanted to highlight this. You can just have a look in the EAU guidelines. Coming on to RPLND versus chemotherapy, which one to follow? And many literature has shown that RPLND is the most effective means of curing the retroperitoneum, because teratoma is present in non-seminoma. In non-seminoma, teratoma is present in about 25 to 50% of the retroperitoneum, and this teratoma is not amenable, does not respond to chemotherapy. And if you leave that teratoma there, in the course of time, it will change into different types of sarcomas. So excision or removal is the best option. And most RPLND series have shown very low recurrence rate, that is less than 2%. The cancer-specific survival after RPLND in MSKCC and Indiana University are found to be very high. There's very good results, and RPLND are more RPLND has shown more favorable short and long-term profile. So this they all say that yes, RPLND is better. You have to proceed with RPLND in non-seminoma. The indication of RPLND in seminoma, I already told you. That is the MCQ or Viva question. This is the anatomical regions of the retroperitoneum. Just like in GI surgery, you in stomach, you divide the lymph node stations into various stations. The same thing here. Here in retroperitoneum also, there are various numbered retroperitoneal stations. And there is usually what happens is that the cancer cells cross from one side to the other side. So it is not that left-sided tumors will stick to left side and right-sided tumors will stick to right side. But generally, a right-sided testicular tumor has the propensity to go into the precaval or interaortocaval nodes, whereas a left-sided tumor usually goes to the para-aortic nodes. However, crossing over is quite common. This is the ideal RPLND template, but the drawback of that is that you damage a lot of nerves. You damage a lot of these autonomic nerves, which lead to retrograde ejaculation. So people have come up with some modified templates in order to preserve these nerves so that the ejaculation is maintained. So what have they done? So they have divided they have found the two different templates. The A is for right-sided tumors, whereas B is for left-sided tumor. You can see that they spare the area of the aorta below the inferior mesenteric artery insertion, because most of the nerves are there. So they want to preserve those nerves and preserve the ejaculation. That is the main idea. Sorry. These are the nerves I was talking about. They are mainly concentrated around the IMA or below IMA. So the main idea was to preserve these nerves and preserve ejaculation. And then that is why the nerve sparing technique came into practice. The antegrade ejaculation was maintained in more than 95% of the patients. A complete resection was complete curative resection was seen in 80-90% of the patients, which was good and complete. But the one thing you should always remember is that completeness of resection should never be compromised in order to preserve ejaculation, because in malignancy, even if you leave a small thing there, the overall survival and the prognosis decreases drastically. So if you see something is there, and in order to, if some node is there, you think it is positive, you have to take it out. That taking it out would be better than rather than leaving it there in order to preserve the ejaculation. And you have to discuss these things to the patient before going in for surgery. This is one of our patients who underwent RPLND for left-sided tumor. We followed that template, left-sided template. You can easily see the IMA, kidney, ureter, the left renal vein. This was the specimen. This is another patient. The Babcock is holding the ureter. This is the team, happy team of a very difficult RPLND. This study tries to see what this study tries to show is that the prognosis after primary RPLND or after post chemotherapy RPLND is much better if you have to do a redo surgery. If you do a redo surgery after recurrence, then the overall survival, disease-specific survival, everything comes down. So at the first setting only, you have to try to complete the surgery so that it does not recur in the future. Because if it recurs, then the prognosis is bad. Colon study group, it is mainly for post-chemotherapy RPLND. They try to compare both modified and bilateral templates, and they have seen that significant difference in post-op morbidity between the two, but non-significant relapse rate. So even in the post-chemotherapy setting, they say that the modified templates can be used because the overall survival and all does not depend that much, but the morbidity, ejaculation, and so on and so forth, and they are different. So it is better to stick to modified templates, either in case of primary RPLND or post-chemotherapy RPLND. This is the conclusion. And if you do one thing in post-chemotherapy RPLND is that in post-chemotherapy setting, there is a lot of adhesion and all. And because of the adhesions, you have to do something additional surgery. Like the chances of having to do something else is high. Something else means where either you have to do a nephrectomy or resection of IVC, then you have to something else. So these things you always have to keep in mind, and the resources should be there, expertise should be there in handling a post-chemotherapy RPLND. RPLND itself is a difficult surgery. Post-chemotherapy RPLND is a very, very difficult surgery. So expertise should always be there and should not be attempted without such expertise. 2A, 2B non-seminoma and normal serum markers and less than 3 RPLND plus minus adjuvant chemo based on the reports, histopathology. High serum marker or more than 3 centimeter nodal mass, chemotherapy, then post-chemotherapy RPLND for anything that remains in the retroperitoneum. Because anything that remains in the retroperitoneum can later on change into sarcoma. As I said earlier, these are non-sensitive things. So it's better to take it out. 2C3, induction chemo, post-chemo RPLND, and post-chemo surgery for anything that is remaining and not responding to chemotherapy. This is the follow-up schedule for metastatic in non-seminoma. As per UAU guidelines, you can have a look. So to conclude, yes, you have to be aggressive in treating a testicular cancer, but aggressiveness does not always mean surgery. It is a multimodality treatment, and at times you require expertise and your clinical knowledge as well. Thank you. Dr. Bikal,
thank you, Dr. Umesh. Are there any questions? And you all, if you have any queries or questions, please feel free to ask. You can message in chat as well.
Or you can give me a call later also, no problem.
Thank you, Dr. Umesh. Since you gave such a wonderful and elaborative discussion on the tumor, I think most of them have already understood everything about it.
My aim was just to sensitize the residents. The book is always the best teacher. You can always go and have a look at the Campbell's urology. But I was just trying to stimulate them, and trying to let them know that testicular tumor is a very important topic, and you should be very careful when deciding. That's it.
Hello, Umesh. How are you?
Thank you so much. Thank you so much. You joined late. We already almost finished.
No, no, I was there. I was there in the middle. Something
Oh,
happened, so
really?
I was in the middle. I was
Today
okay.
I'm having a
Anyway,
little sore throat, so my voice maybe a little.
your voice was fantastic. Don't worry.
Ah,
It was a very, very, very elaborate one. And then even I learned something from you. A
that's
lot
great.
of yes, a lot of things that you tend to forget if you don't study, right? So this was a quick recap from your side, and then it was a good for resident also. So
Thank you
one
so much.
thing,
Thank you
one
for the
thing, one
opportunity.
thing, yeah, one thing the residents should know is any abdominal examination you're asked to do, if you forget to do a hernia test or a
Test
testicular
examination.
examination, you
That's a
fail.
blunder. That's a blunder.
You fail, right?
Yes.
So whenever examiner says examine the abdomen, always finish with hernia and then the testicular. Even you have to do a rectal examination.
Yes.
So this
Yes,
is
of course.
mandatory. This is
Yes.
mandatory. So another thing that you have pointed out is hydrocele. Secondary hydrocele always should be taken into account.
Always, always.
So okay, so do ultrasound, and then instead of making a stage one disease stage four or stage three, whatever you say,
Just
so
do an
it's better.
ultrasound, then proceed.
Yes,
Do not
yes.
just think it's a hydrocele and just.
So I have one question. I have a patient right now. I have a patient right now with intratesticular tumor on the left side,
Mhm.
right? So he did ultrasound, then some other center they did an MRI, and then it is only intratesticular, probably stage one, when a
Mm.
T1 S disease. There's no lymph node, there's no reticular lymph nodes, or so I've sent for chest
Mm.
CT scan, and the upper abdomen CT. So what do you suggest in this case?
Is,
Do
is
you
the
go
is
for
the is the contralateral testis normal?
normal, and then all the tumor markers are normal, right, within the normal range?
No, no. I mean,
And,
is the contralateral testis absolutely normal?
yes, normal.
You,
Yes, it is.
you
He is a
can
19-year-old male.
you can keep the option of partial orchidectomy in mind, always in mind.
Partial
Yeah,
partial octane. And what do you suggest? Do you have to rule out the cannonball appearance in the chest, right?
yeah, yeah. You have to do a
So
CT chest.
CT chest or a X-ray, which do you suggest?
CT chest. CT
So
chest, abdomen, pelvis is a must. Even
so
guidelines
you
recommend. Yeah.
so you cannot just do a chest X-ray and then say there is no meds, right? So
No, no, no.
always do
You have to do a set proper CT.
so proper CT. Okay. So intratesticular, it is about two cent. No, it's about 1 centimeter mass intertesticular, completely intertesticular.
Um,
So what you do an inguinal approach, do a partial and then leave.
Inguinal approach, mobilize the testis out from the inguinal wound, do a
Okay.
partial, then close it, then send for histopathology. If frozen section, then do a frozen section for margins.
We have frozen. Yes, yes.
Then wait for frozen section. If negative, then close it. The
Then
one thing
how do you localize
uh, you have,
during
you may need
during
to do
surgery?
a ultrasound in drop also, like just like doing localizing small renal mass while doing partial nephrectomy.
Okay, okay. And then you have said about sperm banking. That the patient was very much concerned about his sperm. So I did a
Yes.
sperm analysis. It's okay. So once you suppose I may not be able to do a partial. In that case, I do a radical orchidectomy,
You have to give
and
him the
then
option of sperm banking. Yeah.
there's no place where you can do a sperm banking, right? In Nepal.
I don't think there's a. I don't think there's a place.
So what do you suggest?
Then he has to
How
go.
do you how do you counsel the patient?
He has to go to India. There's no. I don't think there's any place in Nepal
No,
which
no,
does.
no, no, no. I mean to say in terms of having one testis and then getting married later on and then having children. How
Then
would you counsel? How would you counsel those patients?
I will tell him that probably most of the patients do not require chemotherapy in this kind of scenario. So if he does not require chemotherapy, then chances are that he may have a child in the future. But if he
Yes.
needs chemotherapy, then chances are
So
very slim.
the residents should always know about this. Always the external will have a habit of asking. So one testis is gone. So then how would you counsel the patient with one testis? Will he be able to have children, or will he not be able to have children? how do you counsel? So you always say you have to follow up the patient. If there is recurrence, if he has to go for the chemotherapy or radiotherapy, then he has to go for sperm banking if he is to continue his married life, right? Otherwise, you have a surveillance. This is always the question that been asked for the MS resident. Yes. So I want to ask if there are any question from the participants, from the residents. I think there's one question. Let me see. There's one question. Okay. Can you see the chat box, please?
In a patient with no pre-op USG during a hydrocele surgery, scroll approach, we find testicular mass. How should we proceed? That's
I
what
think you
we
have
are
already.
explaining.
Yes, yes.
That's why that's what we try to teach them, that you have to do an ultrasound beforehand. If you find, then you go take it out from the inguinal approach, then come do a complete radical architectomy. Then
But
remove.
yeah, he has already done a scrotal approach. How would you proceed?
No, it's open from the inguinal region, take out everything, spermatic cord and testis, also a part of scrotum.
Yes, yes. But you have to do a hemiscotectomy.
Hemiscrectomy, yeah.
Yes, yes. You have to do a hemiscotectomy in this case, and then do an inguinal approach to remove all the at the deep inguinal ring. You have to cut everything and then take it out and do a hemiscotectomy. To be
And
on the
one
safe
thing,
side,
one thing
right?
for
And
the
then
residents is, while tying the vasa things in the deep inguinal ring, always use a non-absorbable suture, so that later you can identify it.
okay, that's a good point. Okay, okay, yes, okay. Proline would be the best, right?
Probably even silk will do.
Silk will do, yes. Okay. So any more question? We would like to wrap up. If there are any questions
I think we should wrap up. I'm having a
from the
bad
resident,
sore throat.
I think Dr. Umesh would be happy.
I'm having a sore
Dr. Umesh
throat.
would be happy to. No, forget about sore throat. You had a good webinar. Everybody's happy. So
Thank you.
your
Thank you so
sore
much.
throat will go.